Hey, well, welcome into The Compass, which is guidance for your journey. I'm Tyler Feller. I'm here with Dr. Brad Robison, MD. And Dr. Robison, quick question. Why did you become a psychiatrist?
Hey, yeah, thanks for meeting with me and kind of guiding us through this conversation. Started out doing pediatrics, and that was kind of more the direction I thought I was heading when I was younger. But as I went down that path, I have always been interested in working with kids and families, and found myself more and more drawn to the kids that are struggling with behavioral and emotional difficulties, unfortunately dealing with the reality of kids that are, struggling with some suicidal thoughts and hopelessness. And so those are the kinds of things that really drew me in. And I found that, I could do the pediatric stuff. But the reality is, part of it, Tyler, was I began to realize that I had some gifts, some calling, some direction, some skills that maybe not a lot of other people had, or at least there weren't a lot of other people going into that field. And so it's like, well, there's a lot of people that are, doing the trauma work and learning to work with kids that are sick, or unfortunately, learning to work with kids maybe after they've attempted suicide and they have to, but I found myself really drawn to working with kids before they have done that, and feeling like that was the place that I wanted to be at in my career.
I love that your approach is different. It's not 15 minutes in and out. It's an hour at least with every single patient. And you're hoping to develop meaningful, long-term therapeutic relationships. And I find that so interesting as we went into a time with the leadership team where we really were focusing on who is it that we're trying to communicate to and why. And we realized that it's actually the mom, and we have a name for her. Her name is Betty Gone Bonkers. Can you talk a little bit about her?
Yeah. I hope moms out there don't find that a negative. It was.
Yeah, I hope they relate to it. Like, yes, that is me.
Exactly. I hope they relate to it, because that's really how, when you were helping us and our leadership team kind of think through this and talk through this. I mean, Paula and I, my wife, who also runs the business here, have been doing this for a long time, but we've been finding ourselves, working with younger clinicians, and that's where our leadership team came from, and why we were kind of looking at all this and talking about, like, okay, what are we really focused on? And we realized that who we're really focused on the most here in our practice is usually mom, sometimes dad, who is just really, busy with life and feeling, the pressures of normal life and the normal pressures of raising kids, and then find themselves in situations that are bonkers, that are just, oh my gosh, this is like, and I think the thing that we've emphasized, and I would want to emphasize in this conversation, is it's not, Betty, the moms. I mean, 9 times out of 10, it's not that there's something wrong with them, but the situation that they find themselves in, a child with a severe mental illness, a trauma that's intruded its way into their family, a massive loss. I mean, those are just, I often say that, as a psychiatrist, it's a negative pejorative term that people say, oh, you see crazy people or something like that, bonkers people. No, what I see is very healthy, wonderful, great people who are in terrible circumstances that are crazy making, that are just are would make us all feel like, oh my gosh, we're just going bonkers here. And so, I hope moms that might be, watching this, listening to this, can really identify with that it's the circumstances that families find themselves in sometimes just feel so, unsettling.
And I think
And
that's one of the ways we tried to identify it. Like, they've tried every kind of parenting technique. The school says one more time and they're out the door. And it's just like down the list and they're at
yeah,
wit's end. And
yeah.
so they show up with you and they're like, I've gone bonkers. Like, oh, we need help.
Yes, exactly, exactly. I mean, I have so many families. I have, you know, I remember I still work with this young man. He's a young adult now. I still from time to time see his parents, but I had worked with them off and on for quite a while. And I think he was it was at the beginning of his fifth grade year. I'd already worked with him for a couple of years, and I remember his dad so clearly coming in here one day and saying, he was just frustrated. I mean, he was like understanding, and he was like, I get it. I know that his fifth grade teacher is well meaning, and he
Yeah.
wasn't trying to knock the teacher, but he was just in frustration saying, I don't know what these people think. Like all of a sudden, we just got this kid this year. Like we've been
Mm,
trying to work on this for the
yeah.
past 5 years, and and now a new person comes along and they think they've got the answer. Well,
Yeah.
we've been trying to find if the answer was easy to find, if there was a switch that we could have flipped, we would have flipped that switch a long time ago to make this all better. And so that's
Right.
a lot of what we deal with is we come alongside families, and work with them where they're at, and understand that their situation is unique, and that we hope to be able to offer a lot of expertise and support and a lot of help that makes things better. But one of the things that I think maybe does set our practice apart is like a huge part of our goal and our core belief is that the most important thing we offer is the willingness to walk the journey with families, because it's hard, and sometimes there aren't easy answers that
Yes.
just make this better and go away.
Now, I think in the back of the mind of some of these parents, they might be asking, because I think it's the worst case scenario possible, is my kid capable of violence towards another human?
Right.
Are school shooters, parade shooters? I just said those things because they're culturally relevant today, but violent possibilities, are those indicators identifiable and preventable?
Right. Yeah. Yeah, I mean, obviously everybody's in our culture's worried about those things. And in a you know little video clip here, I don't know that I'm going to be able to have any profound answers for anyone, but again, I think our goal is to come alongside and walk the journey with families when they are dealing with kids that are struggling with aggression or violence or have had trauma and all of those sort of things and so again, the vast majority of 99.9% of the families that I work with, the kids aren't going to become the next school shooter or anything like that. I mean, I think the very fact that the families are walking in the door and looking for support
Yeah.
is the most telling sign that they're on the right track to offer just love and support for their child, and those kind of things to ensure that the child grows and matures and moves past whatever it is they're struggling with.
So, what are some of the most common mental health diagnoses that you're seeing?
Yeah. I think, I mean, in terms of diagnosis, I mean, yeah, we see certainly a lot of the, ADHD and mood disorders, depression, some bipolar disorder, a lot of anxiety disorders ranging from just generalized anxiety, which is a physiologic, genetically predisposed, diagnosis, versus adjustment disorder, where just stressors and things that are going on for the child or the family that might also be causing anxiety, but it's not necessarily neurobiologically based. OCD, we see a lot of OCD because it's OCD is something that's fun to treat because a lot of times if you get the treatment right, it gets a lot better. But it it sometimes is a little hard to identify in younger kids, and so we end up those kids get referred to us a lot. So we see a lot of OCD, and unfortunately, I mean, we do see a lot of trauma related issues, kids that have experienced trauma in various ways. And so we work with that a fair amount. And, eating disorders in adolescents is common things that we deal with.
I find it interesting when you talk about OCD because when we were going through the different diagnoses and we actually made a video series on several different diagnoses, there are things that you were saying about OCD, for example, that were not your typical sort of symptoms or I don't know what you would call them,
Yeah.
things that you see in people that I didn't realize was OCD. Can you talk about that for a second?
Yeah. Like one of the things that people don't recognize in kids sometimes, or it's a little harder to recognize in kids as OCD, is a reassurance compulsion, which is one of the most common compulsions in kids. In adults, we think about, and it's kind of a part of our pop psychology, mindset of OCD that it's intrusive fears of germs and then repetitive hand washing. Well, that is a common kind of obsessive compulsion pattern. But in kids, it's actually one of the most common patterns that I see is reassurance compulsion. I mean, the young man that came in and, he was, I think, a fifth or sixth grader, and his mom was, talking with me, and we were reviewing things, and she's like, he comes in, and says like 100 times a day, Mom, I love you. Do you love me? And I was like, oh, okay. He's kind of, anxious about that. And she said, no, you don't understand. I counted it one day. He said it 100 times in a row. And I'm like, oh,
Uh-huh.
okay. Got
Yeah.
it. That's OCD,
Yeah. Yeah.
yeah, that's one of them that,
Ding, ding, ding.
yeah, right. Yeah.
uh, I love how when you meet a family, a lot of times they're children, and then 20, 25 years later, they're still coming to see you.
Yes. Yeah. That's one of the beautiful things I feel very thankful for in my career, that I do have that young man. I still see he's married, and he's working, and he's doing very well. And I mean, it's like people come in to see me. I mean, I don't have any strings that bind them here. I mean, it's they keep coming back, like that young man. He keeps coming back, hopefully because he feels like what we offer is supportive and helpful for his journey, even at this stage of his journey, even though his OCD is overall really very well controlled. But we
Yeah.
still talk about life and the transition from high school to college, the transition from college to career, the transition. He's been married a couple 2-3 years now, and so we still make sure if he like he's on some medicine now. There for a while he wasn't, but we'll if there's medicines are still needed, we'll make sure that that's all adjusted right. But we're also providing, I guess that's where my primary care pediatrics comes in, because I still see a lot of what I do as like just primary mental health care, like anticipatory guidance. Like, yeah, let's just talk about life stressors and what's going on now and what's kind of right around the corner in this whatever developmental phase that you're in. And so that's one of the beauties of being able to build long-term relationships and those kind of things.
Now, how has mental health landscape changed from when you initially started your practice to today? I'm sure there's some
Yeah.
similarities, but also some major differences.
Yeah. I mean, the I think the landscape has changed in a couple of ways. One, I mean, I do think people are more open to recognizing mental health issues within their self, their family, their children, which that part of it is a good thing. I think there's pros and cons to the pressure towards medicalizing everything from, the standpoint of a diagnosis and medicines and all of that. I mean, that's part of what's evolved. That was already kind of taking root at the early phases of my training and my career, but it's really, just expanded. I feel like, or I hope the pendulum is swinging back the other way a little bit, to where we're recognizing that the role of a good mental health professional, psychiatrist, nurse practitioner, therapist, is certainly, there's value well beyond, a biologic diagnosis and a prescription for some pill or something. I mean,
Right.
I do that. Those things are important, but it's, the whole picture of the
Yes.
child and the individual is so much more than that. And I hope that we're coming back to being able to embrace that more uh,
Yeah.
in the next several years.
I'm right there with you. Now, we've had a big emphasis the past several weeks on play therapy. Can you talk about that for a minute?
Yeah. Um, Play therapy is a I mean, play is the language of children, in so many ways. And so play therapy is really just the therapist taking time to immerse themselves in the child's world, and be willing to engage in the process of play.
Hmm.
And play therapy has been around a long time. It The core of play therapy, while play therapy can be very prescriptive or very skills based. I mean, there are elements of play therapy that are about teaching skills. Play therapy at its core is still a therapeutic process that just is more immersive into the child's world,
Yeah.
and the metaphors that kids develop in play. I mean,
Yeah.
that's what play is about, is working through issues in metaphor. And it's a lot of fun. I mean, it's and very helpful for kids. I often, look at play therapy, like I said, it's probably, play therapy would probably be good for everybody, just like therapy, is probably good for every adult. Play therapy would probably be good for every kid, but I don't necessarily feel like every kid needs to be in long-term play therapy. There are some things that are just, let's just work on some basic skills, or let's work on some basic, you know, parent support and helping parents kind of work on some basic behavior modification. But then there are other things like some more chronic anxiety, chronic depression, trauma related issues, disruptions in emotional growth and development, where it's helpful to have a good play therapist who can really connect with the child long term,
Yeah.
and really allow that child to just explore their world and around them, and their inner emotional world in a safe space that allows play, to be a part of what they're doing.
If there is a huge wait in order to see a psychiatrist, if we're talking about Betty gone bonkers, what can she do while she's waiting with her child?
Yeah, that's a real issue, and we've worked really hard to try to address that. We are working hard to try to address that. I used to accept it as just a reality. I still do accept it as a reality, in a sense, in that my commitment is, I want to make a commitment to be available to my existing patients. Um, because of that, I try to make sure I carve out plenty of time to have follow-ups and all that, and so that I don't just take, I don't fill my schedule full with new patient evaluations. The downside of that then, for families that are trying to get in, is sometimes there's a wait. The upside of that is, once they're in, I do try to make myself completely available to them and get them in as frequently or as they need. They've got access to my phone number. They've got access to, so I really try to make sure that once we're connected, then we're able to really walk the journey with folks. I have, we've got therapists here. I've trained nurse practitioners. I'm in the process of training. I just had a new nurse practitioner start that I've trained, and I've got another young lady that I've worked with for several years, and I'm training, and she's in the process of becoming a nurse practitioner. Actually, two others. So we're working on trying to, help with that. But what do you do in the meantime? I think, there are a lot of really good pediatricians in the area that, do find themselves treating a lot of mental health issues. I think that's always a good starting point. They can always call. We can usually get a therapist, here at our office, or there are other, really great therapists in the community. Those are options. I think, I know it's hard for families to try. That's part of why we've started the Compass and are trying to, get it up to speed here over time. Because I know it's hard for families to find resources, but one of the things that I think a busy family can do is to carve out time to really learn and read and research. That's always it's a little bit of a scary proposition because there's so much junk out there, that people can go down a rabbit hole and get themselves really fearful, and the internet will never really replace just good, meaningful, helpful therapeutic relationship, but the process.
And by the way, we have a list of those approved resources on the website, so people
Yes.
can go to bradrobisonmd.com and click on the compass, and boom, there it is.
Yeah, we're developing that and trying, and that's part of the whole emphasis of these videos is trying to provide some good information, and there's other good information out there through some nationally recognized, the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry. There are some good clearinghouse of information out there, and so being willing to learn. Like the families that I work with that I feel like do the best, that have the best outcomes, are the families that I've got a lot of moms and dads. I don't want to leave the dads out completely. I've got a lot of moms and dads that we tease about at this point, that they've got their own, PhD in OCD or whatever, because they've just had to really dive in and learn. And I think that's critically important. Another thing that you've heard me say before, and I repeat it a lot to trainees, and I'll talk to moms about it too, is I still remember Dr. Palmer, one of my mentors in pediatrics many years ago, and he was an older emeritus professor, and he would always ask us, our first year pediatric interns, one of his questions early on would be, do you know the number one rule of pediatrics? And everybody would be coming up with whatever fancy idea or answer they thought it was. And he would kind of smile and say that the number one rule of pediatrics is mothers know. And he's right. Moms, the vast, 99% of moms inherently know. They may not know all that I know about OCD, for example, but they are the expert in their child. And so my job is to just help them continue to grow in their expertise in their child. And so what can a mom do or dad do? Take the time with your child, become that expert in what they have that's going on, mostly through just time with your child, but also through reading and research and talking to, good therapists and pediatricians and people like me.
Well, Dr. Brad, thank you so much for your time. Is there anything else you want to add today?
I don't think so. Again, I hope that Betty the harried and hurried and overwhelmed moms and dads out there will find this kind of comforting and reassuring from the standpoint that it can be overwhelming when you're faced with mental health issues and struggles with your child. but there is help, and I do get to see great great stories of recovery and kids doing great, as 20 somethings now, so yeah.
Well, if you're watching and you're interested in making an appointment, you can call us at 573-334-7055, and we will get you on the books if we can, and we'll point you to some resources as well. And Dr. Brad Robison, thank you so much for this episode of The Compass, guidance on your journey. And we'll be back every month. We're going to be doing this every month. So thank you, thank you, thank you.